right. Hi, Dr. Gutierrez. Thank you so much for joining us here at DSST today. Students are super excited to hear from you and learn about your perspective in medicine and how your career has been impacted by COVID-19.
Thank you for having me.
Who you are?
What was that? Sorry.
Do you mind sharing a little bit about who you are and what your background is?
Yeah, so I'm from California originally, Sacramento. I had a different way of getting into medicine in regards to I didn't go to a four-year college right after high school, but I did community college for a few years and kind of found myself and what I wanted to do, and then ended up going to a four-year and then transferring and getting to med school.
Cool. Where did you go to medical school?
I went to the University of Minnesota in Minneapolis.
And where are you right now?
And currently I'm in Long Island, New York.
Can you tell us a little bit about what happens after medical school?
After medical school, so essentially you have to choose a residency of choice, and then once you they call it a match process. Once you match into a spot, you kind of have 2 months essentially to kind of pick up your life in the city you're at in medical school, and then go to the new city where you're at. So for 4 years I spent my life in Minneapolis doing medical school, and then I opened an envelope one day and it said that I was going to Stony Brook University Hospital for my residency, and I had to pick up and move here, and here I am.
So medical school is really the first bit of training for doctors.
Yeah, so for medical school, usually it's broken down into the first 2 years is kind of your traditional. It's kind of like undergrad, in college, where it's just classes all day, and it's a lot of tests and just reading. In the last 2 years, it's more clinical, where you're in the hospital, you're learning kind of more hands-on that way.
So what is your residency right now at Stony Brook Hospital?
So I'm in a 5-year program. It's a vascular surgical program. And it's a little different. Typically for vascular surgery, there's 2 ways of being a vascular surgeon. There's you can be a general surgeon first, which takes 5 years, and then you would do a 2-year fellowship afterwards, a 2-year vascular surgery fellowship. Or if you know what you want to do from the get-go, you can do what I did and just apply directly to a vascular surgery program.
It's a lot of training. What is vascular surgery exactly?
So essentially, a vascular surgeon, it's really cool because it's a full anatomy job where we work on all the arteries and veins in the body, from the toes all the way down to up to the neck. Anything that goes inside the cranium or inside the bones, we don't touch. It's more neurosurgery. But from essentially from the head down is our area of play, essentially.
Very cool. Now, of course, here in Denver, just like the rest of the world, our lives have been altered pretty significantly by the pandemic, as you can imagine. But being stuck in our homes and doing online school, we're not always able to fully understand what life is like for people on the front lines and in the medical field. So some of our students from DSST have questions about your experience with COVID-19. Is that all right?
Yeah, definitely.
All right. Miranda Herrera from Green Valley Ranch is wondering how the coronavirus has impacted your daily life and how it's impacting how you both do and view your job.
Yeah, so it's kind of completely changed my training so far, because I would typically be in a surgical type of environment, whether it's on a vascular surgery service or some surgical oncology service or some other plastic surgery service, but essentially just getting surgical training. But since the whole pandemic started, they essentially pulled every resident from every other program, whether it's OBGYN, it's neurology, psychology, pathology, and they're having us now on these special COVID teams. And essentially I'm kind of a medicine doctor or medicine resident. Sorry. There we go. But so yeah, I'm not doing what I want to do, but it's fine. We're all helping now. And then in regards to daily life, I go to work and I come home like you guys. I just stay home. And that's pretty much it.
So it seems like you were kind of shifted very quickly out of your training program?
Yeah, you know, it kind of like just one day. It was very interesting just to see the evolution of how everything kind of panned out, because at first, you know, the hospital um, just stopped having any visitors, period. And then they, as a surgeon, you know, we want to do surgery, and so it later progressed to where they stopped all elective surgeries. And so things really slowed down. I feel like people were scared to come into the hospital, so we were getting less, you know, consults from the ED. And typically, vascular surgery, the patients they have acute issues that usually need to be dealt with pretty, you know, quickly. And we weren't seeing these, you know, these typical patients coming in through the ED or calling the clinic for help. So that's kind of, it was a very like, yeah, it kind of slowly evolved into what it is now.
So coronavirus initially like overshadowed every other issue that people might come into the hospital for.
Yeah, essentially, our hospital turned into a COVID hospital.
All right, our next question is from Maria Cervantes from Cole High School. And she's wondering, what does patient treatment look like for people that are admitted with COVID? And kind of building on that, what signs would you look for to determine if someone has COVID as opposed to another respiratory illness?
Yeah, so for our hospital, I think maybe some other hospitals around the country too kind of did um, a similar plan. So typically a patient, you know, in a normal situation, a patient would go to the ED and we get
Can you tell us
triaged.
what ED means?
Oh, so the emergency department
Thank you.
would come to the ED and would get triaged by the nurse, and then they would come into the ED. But you know, with the high volume of patients that were coming in, the high risk, they kind of set up a field out in the parking lot for kind of like a tent ED essentially, that would kind of like assess these patients, and if they're deemed to be, you know, high risk or, you know, COVID-like patients, they would send them to the ED from the tent triage area. And typically, how it worked from my perspective, you know, they would call me, the ED would call me and say, hey, we have a patient that's, you know, we think it's COVID positive. We call them PUIs, which is a patient under investigation. And so, you know, typically what I do is I get the name, the MRN, which is like kind of the ID of the patient. I look them up on the computer, and I go through the labs, you know, and what kind of oxygen requirements they're having, what's their past medical history, because, you know, if the patient has diabetes or COPD and different kinds of medical issues, it kind of makes things more complicated and a little bit more worrisome in regards for having the virus.
Is there something unique in the lab work that like sticks out for COVID patients as opposed to another viral infection maybe?
Yeah, definitely. So, I mean, again, this is kind of all new to me. So, like, I was like learning all of this, but you know, after doing this for the past month, you kind of figure out what a COVID patient looks like in regards to the lab. So, typically, you get, you know, for any patient that comes through the ED, you usually get a pretty standard workup of labs. Again, we call a CBC, which is essentially it's your blood cells. The way we can see kind of infection, we would get a Chem 8, which is essentially looks at your electrolytes, your kidney function, your glucose levels in your blood. But with these COVID patients, what we would find is that we would order additional labs that are markers for inflammation, essentially. So CRP, ESR, ferritin, these are all indicative of inflammation processes going on in the body.
And inflammation is a result of our immune system working, correct?
Correct, yes, yeah. So if you have an infection, your body reacts to it in regards to an inflammatory response. And so you have these markers that go up and that would indicate some kind of infection. In addition to these inflammatory markers, they would have like an elevated D dimer. A D dimer is essentially a breakdown. So your body forms a clot. A clot is formed by fibrin, and the breakdown of that fibrin is a D dimer. And so usually it means, you know, a few things. It's not specific for, but it could highly suggest, you know, some kind of like a coagulation event going on in your body.
So I want my blood to coagulate if I get a cut or a scrape, right?
Correct.
but I don't want my blood to coagulate as it's flowing through my veins and arteries.
Yeah. So essentially, like the blood clotting system is actually very complicated, but essentially, like your body, it's like a tier system where there's a balance. You want, your blood to be thin enough where you're not clotting, but you also want to clot in case you cut yourself with a knife or you poke yourself. You don't want to bleed out. And so, baseline, your body's always trying to balance this out. And when you have, this COVID virus, it's found that you're at very high risk for clotting. And how we find this out is about with the D dimer.
Interesting. So once you have identified that you have a COVID patient, they have high levels of D dimers in their lab work. What does treatment look like?
So treatment is actually, unfortunately, it's very limited. So the main reason why they're going to be admitted to the hospital. So first of all, not all patients that have COVID need to come to the hospital. They say about 80% of the patients, don't need to come to the hospital. They can hang out at home and isolate at home. About 20% of the population actually that have COVID need to be admitted to the hospital. And the main reason for admission to a hospital is what we would call acute respiratory hypoxia, meaning that they're needing some kind of requirement of additional oxygen supplementation because their O2 saturations, which is essentially just the O2 concentration of blood, is quite low. And so usually there's different severities and different grades of what kind of O2 supplementation someone would need. It can be as basic as just like a typical what we call nasal cannula, just two little prongs that go in your nose, wrap around in your head. That's kind of where you start baseline from. And then, if that's not really, meeting their oxygen requirements, you can do a mask. There's different kinds of masks. There's a non-breather, there's a venti mask. You can do CPAP, which is kind of more like invasive type of oxygen supplementation, where it's a mask that it's like really tight fitting over your mouth, and it kind of blows air and keeps your lungs open. And then the most invasive being, what we call intubation, where we put an endotracheal tube down a person's throat for them to breathe.
So the biggest issue with patients coming into the hospital with COVID is them not being able to get enough oxygen on their own, meaning their respiratory system is not able to do its job correctly.
Yeah.
Do you find, I know you mentioned initially that there's not much you can do in terms of treatment besides oxygen. That kind of builds on our next question. Mariela Tapia from Green Valley Ranch is wondering what the hardest part is about being a doctor during COVID-19. And I wonder if that aspect of not really being able to treat patients effectively is one of the harder parts.
I would say, yeah, definitely. It's kind of like I don't want to say a helpless feeling, but it's frustrating because you see these patients, you walk into the room and they literally can't breathe, and it's quite scary to see them that way. And you're doing all you can. Sometimes they have bacterial infection that's going on top of the viral infection, so you can treat them that way. But I mean, really, it's quite frustrating because all we have is just give them oxygen and maybe some antibiotics for any kind of bacterial infection, and then we're using drugs that, like what you see on the news, hydroxychloroquine, which hasn't really proven to work, but we're still giving it to them, and so it's frustrating.
So is the hope with hydroxychloroquine that even though there have not been peer-reviewed trials that
there has been, but they've been kind of like they're early, and they're not really like when a medication or a drug is used, it's a big process, and everything that's been done is all retrospective, essentially, not really prospective studies where you're looking back in history at a medication versus actually setting up like a trial where you do like complete randomized trials, and it's more a prospective approach. So it's not I guess you would say it's not the most ideal way to figure out if a drug works or not.
I guess that's kind of an interesting aspect. Do you think it's possible to be proactive in terms of treatment development for a totally unknown virus?
Yeah, so like right now, like at least my hospital and probably several other hospitals in New York State are part of several different trials. Like on the news right now, you have the remdesivir trial you hear about, which is kind of an antiviral. We're also involved in the trial. So one of the pro-inflammatory markers, IL-6. IL-6 is a cytokine. So essentially, when your inflammatory cell senses an infection, it releases like a signals, which we call cytokines. And the inflammation process is a good thing for your body, but at the same time, it causes a lot of collateral damage because all of the inflammatory process cells, essentially kind of clog up the lungs a little bit. And so the idea with this medication, it's an IL-6 inhibitor, is that if you can kind of somewhat dampen that inflammatory response signal, that you can kind of somewhat control the collateral damage and ease up the lungs a little bit.
Interesting. Well, we're eager to see what comes of those trials. I have one more question from Faye Blakeman from Green Valley Ranch, and she's wondering, we know the stress of being a doctor on the COVID floor must be intense. She's wondering how you're handling the stress of working with COVID patients and how you spend your free time.
So essentially, the free time I get, I sleep, and I just try to exercise a lot. I run. I was playing tennis a lot before they closed the parks, but just trying to stay active. I live pretty close to the water, and so I'll go jog on the beach, whatnot. So just be active. That's my personal way of dealing with things. So
yeah, and getting outside and being active and spending some time in nature definitely has a benefit for our mental health too.
Yeah.
I was curious, I know that you did some work in molecular biology prior to entering medical school, and I was wondering if your experience with that, along with the medical field, has given you any insight into vaccine development and what the trajectory might look like for vaccine development with COVID-19.
Yeah, I mean, I didn't say my experience doesn't directly give me the experience, that would be needed for vaccine development. But I think just the general overall background of the science that it takes to develop a vaccine. Typically, with any kind of drug, whether it's a vaccine or medication you take, you do, it takes years essentially for the FDA to approve it. Because
why does it take so long though? Because we've been seeing on the news that initial vaccines have already been developed. So if we have the technology to do it, what ends up taking so much time?
So the first phase, so phase 1 of any kind of trial, is always to make sure that the drug works. So that's kind of like the number one step, is like, does this drug work? Yes or no? And usually it's not done in humans, it's done in like in a mouse model or just cell cultures or some kind of model system that they can test it on. It's always a question of, does it work? Yes or no? And the next few phases after that is it safe? For humans. And so like actually currently right now, there is a group at Oxford that has developed a vaccine for the COVID virus. And essentially they got a jump start because they were working on a vaccine for a earlier COVID virus, because the coronavirus it's a general virus and there's different strains. And so essentially they were trying to develop a vaccine for a different variation of the virus. And so they kind of had an early start on it. But actually, so for them right now, they're actually testing it in monkeys. And it's showing that it actually works. And so the next part of that would be, does it work in humans, and is it safe for humans to take?
Cool. So like, as you move through the different phases of trials, you're kind of like decreasing the ethical issues involved with a new medication or a new vaccine.
Exactly. Yeah.
Okay. How do you think this will impact the future of your career? Like, do you imagine yourself going back to vascular surgery? Do you see that happening anytime soon?
I think so. Actually, it's funny because we got an email today for us. Like I said before, the acuity of our type of patients and the surgeries that we do are patients that have like, a cold leg, where they're at risk of losing their leg, or, they're at risk of, rupturing their aorta. So the things that we do are a little bit more higher acuity. And so it gives us a little bit more flexibility in regards to doing surgeries. And so as of today, our hospital policy, a lot of the things that we do personally will be back to normal. But I think the whole idea of normal now is different from normal, 2 months ago. So we have to get kind of used to what the new normal is.
So like life will go on, but with new precautions.
Yeah, essentially, yeah. We have to just kind of adjust to what, we don't know what the new normal is going to be for the hospital policies, but yeah, there's going to be a new normal for us.
Good. Many of our students here at DSST are super excited to pursue careers in the medical field. What advice would you offer to students?
I would say definitely, just like take a big look and to see if it's what you want to do. Because, I wouldn't change my path or what I did or what I'm doing now, but it's a big sacrifice that you have to take on. And you have to be willing to and I think it's early on, it's hard to fully understand what that sacrifice is. And there is the sacrifice part of doing medicine, but when you're in med school and you're struggling sometimes, because there's highs and lows, mostly highs, but it's not easy. So I was just, I would say definitely, really ask yourself, is it something that you want to pursue? Because it's a big sacrifice. Because, for me, I've been away from my family for the past, let's see, 4 years in med school and 5 years residency. And so there's that component, and then there's a time component. And, but I mean, I wouldn't change what I wanted. I'm not trying to tell them you have to do medicine, but it's something that's difficult. I really want to do.
Having a clear vision for what you want in the future helps you get past some of those challenges.
Yeah.
Cool.
Trying to think what else I can say about medicine. I love it. I mean, it's tough. My life now it's tough. My free time is not ideal to most people, but I mean, I love what I do. So
great. Well, thank you so much, Dr. Gutierrez, for spending time with us today and sharing some of your experience. We know that the students at DSST will be very happy to hear from you, and hopefully some will follow your path.
thank you for having me on.